And we're back with Chris Lefever. Chris, this is your first time on. I'm stoked to have you on. This is our first time actually chatting as well. You had messaged me and we've communicated a few times on social media. But really what sparked the goal of this conversation or the topic is a few months back, I had a post, I think it was titled Red Flag Rehab Narratives, and that'll likely be the actual title for this episode, but kind of quoting common things that are said in the physical therapy, rehab, and performance realm by clinicians and what patients and athletes end up bringing up. And I think you made a comment just diving into like, how do we even navigate some of these not so great narratives? And I just reached out to you and thought, well, let's have a live discussion of how do clinicians manage things that are said and believed by athletes, patients, and other clinicians. So that's where we are. Chris, thanks again for coming on. Can you tell the people about yourself?
Yeah, for sure. And thanks for having me on. And I've said this to you a couple times before, but you and E3 and a couple other folks out on social media, Adam Meekins and Eric Mira and Chris Juno, and I like Mike Reynolds stuff too. You guys are few of the names that actually believe in and follow and use some of the content that you put out with athlete care and education. So thanks for all you do in trying to clean up all the nonsense that's out there surrounding PT and some of our affiliated colleagues in our other neighboring careers. But yeah, so my name's Chris Lefever. I've been a PT for approaching 10 years, I guess, at the end of this year. And so my entire career has been almost entirely in sports. I graduated from Slippery Rock University outside of Pittsburgh. I did a sports residency program at Memorial Hermann Ironman Sports Medicine Institute. Now they're called the Rocket Sports Medicine Institute current day. After that, did a Division One sports PT fellowship at Duke, and then the highlights of my career. Essentially, afterwards, moved on to the USOPC. So I worked for Team USA out of the Olympic and Paralympic Training Center here in Colorado Springs, and I've been here for about 5 years now. And so originally from Pennsylvania. My wife is a retired Olympic swimmer. She was a long distance swimmer, so she's kind of been in the sport world her whole life as well. And has lots of funny things to say about PTs and folks she's interacted with over the course of her career. And we're expecting our first kid. We're having a boy in September. So that's a snapshot of life for me right now. But life is good, and it's a good gig out here in Colorado Springs in a pretty unique setting, working with the Olympic and Paralympic population.
Yeah, that's amazing. And a very unique setup you have. And I think that will also be helpful for this conversation to maybe show in some of these most elite settings and with the elite athletes, there can still be, or even maybe even more so than a typical setting, some things that are said and done that maybe aren't the most evidence-based or that are really hard to
Mm-hmm.
navigate as a clinician. So we have a lot of range in this conversation and we'll see where it goes, but maybe we can just start out with some of the most common kind of unhelpful or incorrect rehab beliefs that you hear from athletes on the day-to-day, or the ones that have just stood out the most over the past few months or years that you've been in this current setting.
Yeah, that's a good question. I was brainstorming a little bit this morning, knowing we were going to get into this, and I have a long list of bullet points here. But I think, just to throw out the biggest ones I probably hear on a weekly basis: innominate rotations, leg length discrepancies. I feel like vertebral subluxations are slowly kind of being weeded out as the chiropractic field becomes more evidence-based with these newer waves of graduates. And so I don't think we hear that as much, but it still happens. I think I just hear generally, if someone's sore, they just say I'm out of alignment and I need to go in and get, my round of, manipulations. Uh, Ribs out of place, rib dislocations, which are probably just cranky costovertebral joints. Um, you know, uh, like specifically dry needling, people who feel like they need a specific twitch where you use that dry needling, and we can dry needling, whether it works or not is another conversation, but you probably shouldn't be like locked into that narrative. You need a twitch for it to be successful. Just like if you want to have a manipulation, you don't need a specific segment to cavitate to have benefits from it. And so those two things are big. And The population we work with here have seen lots of providers, and they have very, very specific expectations sometimes, and that's challenging. And then I know you've done a couple posts on this before, but generally anything PRI-ish, like Phosphor Restoration Institute, and the correctives to fix these really nitty-gritty malalignments, or I'm not quite sure how they define that in that kind of camp of thought, but all that gets really interesting. And yeah, and finally, this one, I think the concepts of regional interdependence. It's like I don't think any PT is going to be like, I don't like the idea of that, because we know segments above and below the joint of dysfunction can be helpful to treat. But I think the further away you get from the joint, the weirder it gets. And sometimes, like I think my cervical rotation is influencing my ankle pain. Like we hear some pretty interesting narratives from some athletes who kind of get really deep into this biomechanic type thing. And don't get me wrong, there's a lot of utility there when used correctly and in an intelligent way. And usually it's simpler explanations than more complicated ones. But I think regional interdependence can get a little interesting too.
Yeah, it's such uh, a hard thing to navigate with any athlete or with any patient on they say something or they're requesting something. As a clinician, how do I go about either agreeing and just nodding my head, or having a more in-depth conversation, and just the nuances of knowing that such a big part of rehab and managing improvement of symptoms and just building this trust is this rapport and therapeutic alliance. If you go about shutting down someone's
Mm-hmm.
significantly ingrained beliefs, potentially that's maybe not the best option. So it's very context dependent and athlete dependent. But like you said, you have these athletes coming in that have probably seen dozens, if not more,
Mm-hmm.
of rehab providers throughout the course of their career as athletes that are now at the Olympic level that are training, and they may have providers that are saying and doing certain things that you agree with, and other providers that they really respect that are doing things that you don't agree with, and then they're coming to you. And how do you manage this influx of things that they're being told and believing? So I think it's helpful to dive into a few examples of times where maybe you realize I'm just going to kind of bite my tongue and develop as much trust and rapport and do what I think is the most valuable as possible, and other times where it makes more sense to maybe have further discussions or dive into more of why they believe these things. So I'll leave it up to you, kind of some examples where you want to start of either of these scenarios of athletes coming in and you interacting with them.
Yeah, yeah. A couple cases come to mind, and I don't know, each one, as with anything in rehab and PT, has to be approached on an individual basis, based on what they're saying and what their beliefs are and your relationship and your rapport. And my role here with, Team USA is very interesting, because the relationships I'll build with athletes can range from someone is flown in and we see them for 2 days and then they fly back home, or someone is brought out for what we call like a long-term rehab program where they live at the training center for months on end and we see each other daily. And so the way that you approach either one of those is very different. And obviously, probably most PTs like the second of those two options, because that's what we do. It's long-term rehabs, and you're with the patient, and probably aside from the athletic trainer in that athlete's care, we're seeing them the most out of anyone in their circle. And so one that always comes to mind, and I'm interested at the end of this story, I'd like to hear how you'd handle it, because this is the case I'd use for mentoring. But and I'll be a little bit ambiguous, but I want to give enough information for your listeners for this to mean something. But I was working in Olympic Games, so when the Olympics or the Paralympics happen, we set up a big medical clinic, and our providers set up there, and essentially we're in the village, and athletes can come in and use us whenever they want. And so we were staffing the village Team USA medical clinic, and just hanging out. It was pretty late. It was like 9:30 or something, and we had an athlete come in, and I'll keep the sport anonymous for the sake of the athlete. And this athlete came in and was competing the next day. So again, like Olympics only happen every 4 years, right? They happen every two, but athletes only compete generally every 4 years. And so the biggest, probably athletic event of their life, maybe one of the biggest moments of their life. And this athlete came in because they felt like a specific vertebral segment was out of place, and they were feeling it when they got into the position required for their sport. And so they competed the next morning. And so, like, that's a pretty, I don't want to say intense situation because it's conversational, and I don't know, there's not many intense things that happen in rehab, life or death wise, but he's worried. And this athlete wanted a very specific treatment for this very specific complaint to tomorrow compete on the largest stage in the world, the largest moment of his life. And that's, I mean, in my opinion, being realistic, that's a pretty hard slam dunk to give someone. And, I kind of reading between the lines, this athlete has probably been told in numerous cases in the past when he's had an incidence of low back pain that it was due to this specific segment that needed to be manipulated, and he felt out of place. So you bring the athlete back, you do your thing. I tried a couple of different, manipulative techniques to try and get him the cavitation or the experience that he wanted, and we couldn't get it. And so athletes obviously not super happy, polite, but you can tell not happy. And obviously, as a provider, I really, really want to give you that cavitation that you think you need to have a slam dunk performance the next day. But you just sometimes you're just not going to get it. And whether, I mean, your viewers, or we could argue, is it a skill thing on my behalf? Did that segment not actually, did the segments in the area not actually need to cavitate? Does he get the intended benefits from the manipulative technique without the cavitation? And we know the answer to that is yes. But he wanted this one specific thing. And so, like, yes, I thought about that for like weeks, right? It's like the biggest stage, the big moment. This is your time to shine, get that pop. Patient feels better. You rocked it. You're awesome. And that's not how it went. And so I thought about that for weeks, and I felt bad. And it's been a good growing point for me and a good narrative. And so ultimately, I think the athlete competed well the next day. But the big takeaway is, like, it's so sad. Like, there's so few things that we do that could really hurt someone. It's like you choose a cervical manipulation in a population that you probably shouldn't have, or you hit a lung with a dry needle. It's like those are two things that are really scary in our field. But it's just so sad to think that this athlete had this narrative implanted in his brain years ago, and you're worrying about it the night before the biggest event in your life instead of getting a good night's sleep. And that's what I reflect on the most. And I tell that story to students that I see giving poor narratives. And it's like the narrative in itself probably isn't that harmful, but people live with that the rest of their life. And it's something that they will continuously go back to when they have pain in that area. And so I got plenty of other stories we can pull from to talk about, but that's probably one of the first ones that come to mind.
Yeah, that's such a tough place to be in. And I think I would have read the situation similarly, where there's obviously a very quick timeline and rushed sense or component here,
Yeah.
and it's at the highest stage for this individual. So trying to break down some of these beliefs that they may have had for months, years, decades, that's just not appropriate. It's unlikely. It's that
Mm-hmm.
person's probably not in the mind state to be wanting that.
Mm-hmm.
They're not asking, what are your thoughts about this? It's like they're requesting. So I feel like you did the best that you could. When that cavitation didn't occur, I'm curious, did you just try to reassure them and be like, hey, the great news is this still maybe provided the relief for what you were hoping for? Or was it just this kind of like anticlimactic? He was like, thank you, and then walked away. How did it end?
We tried a couple of different, techniques, and I said, hey, I know you didn't get the pop you were looking for. Let me try a couple other things. I'm like, worst case scenario is that you don't get this pop, but you get the intended benefits of this manipulation anyway. And so we tried a couple other things, and you do your best to implant some different advice that helps encourage them. I mean, you don't want to like positively prime someone. I try to not do that because I really don't like that either. But you give education the best you can about what you know the intended benefits are and the actual benefits are of getting that. You know, it just wasn't going to be a scenario where this athlete would be happy otherwise. And so, yeah, to your original question, I just went on a rant with the last question. Between the two athletes of someone I see in isolation and someone I see for long-term rehab, the someone I see in isolation, depending on the belief, I'm probably not going to try to debunk it with them because a lot of times they hold those. It's a very deep-rooted thing they've believed for years. But once you have a relationship, that's where you have a little bit more room to wiggle in, and you can politely and gently challenge some different beliefs and some thoughts. Usually, I do it under the context of like humor or sarcasm, intelligently with social awareness. But that's kind of the population where we can maybe make some change in, if you will.
Yeah. Can you give one or two examples where it's that longer care where they're in and
Yeah,
you're maybe slowly uh, tackling some of these things or having these conversations?
yeah. So another case that comes to mind. We'll call this athlete like a pushing athlete. So imagine in your head, again, for the sake of being anonymous, imagine like bobsled, skeleton, or luge. So you're pushing on this apparatus that you're going to jump on down on, and you're going to go 70, 80, 90 plus miles per hour. So I'm working with one of these athletes. And so with this athlete, we're working on, this athlete had some neck pain complaints. And so we were getting some baseline metrics on a couple of sessions in, and we've had a relationship for years. So I felt a little safer to have, good conversation. And so, I'm sure the majority of your listeners are in sports and are familiar with Vald's force frame. And, it's a fixed dynamometer, and you can move it around and you can change the angles and things. And essentially, it's a great way to get some isometric uh, neck force output measurements, right? Some strength profiling, if you will. And so when you do these for the neck, you're in quadruped, you're on your hands and knees. And when you unfold the force frame, there's like a platform, right? And the platform is like, it has to be less than half an inch thick. Like if I had 1 foot on and 1 foot off, I probably wouldn't notice, and it certainly wouldn't be a big deal to me. But this athlete, has been fed a lot of different things over the course of their career from a lot of different providers. And so this athlete is afraid of being out of alignment. Talks a lot about subluxations and asymmetries and trigger points and soft tissue dysfunction, all the things. And it's a conversation point that happens every session. And so what I'm getting at is we got this athlete down in quadruped to do, I think it was like cervical flexion, pushing into the pad with her with her forehead. And so she had one hand on, one knee on, like the little platform of the force frame, and then her other hand and her other knee were off. And she's like, "Is this okay?" I was like, "What are you talking about?" Like, "Yeah, it's all set up. Like, feel free to go ahead and push." She's like, "Well, I'm a little afraid of getting out of alignment." I was like, "This is oh, you're talking about your hand and knee placement." I'm like, "Yeah." I'm like, "I think you are you really worried about that?" And she's like, "Well, yeah. I mean, I don't want to. I work so hard to stay in alignment, and this is going to throw me off." And I'm like, you know what you do for a sport, right? Like you push on a heavy apparatus and you run as fast as you can, violently, explosively, while people line the side of the track and scream at you to go faster, and then you go 80, 90 miles per hour plus in a sport that people have died in. And you're worried about being out of alignment because your hand and your knee on one side is like half an inch higher than the other two for one strength test. And so this is a really hyper specific example, but it's like you sit back and you're like, where did you come up with this concept that this is bad for you? Um, and undoubtedly, it's because someone fed it to her earlier, whether it's a PT or a chiro or an AT or a massage therapist. We all do it. It's so frustrating. And so I poked the bear a little bit on that one and essentially said what I just said to you under the premise of humor. Like, do you know what you do for a living? And I don't know, maybe some of it landed and maybe some of it didn't. But it's kind of sad that that's what we're worried about when we have bigger problems to solve. And it's a recurrent theme, whether it's elite athletes or it's a general outpatient population. It's really hard to address.
Yeah, you trying to navigate that with some light humor, I think that's a great option. Has that ever backfired where you're trying to be light with it and kind of show like the demands of your sport compared to what you're concerned about? Do you see this conflict? Has that ever uh, backfired, or situations where you've tried to create that sense of like comparison and there's been even more of like a strong hold in that belief?
Yeah, it could. I don't, I can't recall any major blowups, and I'm pretty tactful about how I address this. And is probably I should probably try to address it more. And this was an instance where I felt okay too, based on the relationship I had with the athlete, and I think it helped that little micro conversation wasn't necessarily related to the thing that we were working on as a whole. It wasn't like the goal of her treatment program, and so I think that helped it be softer. I would certainly never make fun of or make light of the problem that an athlete or patient is coming in for. That is never my intent. But this one kind of was a little offshoot of something pretty unrelated to what we were working on, and it felt safe to do so. But no, I can't remember any blowups, but I'm sure I'm not immune to them, and I have a lot of career left in PT, and I'm sure I'll get one at some point.
Do you? I've experienced this where I have an initial evaluation with a patient, either in person or remote E3 consult, and let's say it's an hour or however long, and there's
Hmm.
countless things that are being said that I've just like, I don't even know where I would start with, because there's so many different kind of sad, unfortunate beliefs that they have about their body,
Hmm.
or feeling super fragile, or these minute things that they've been told that they are hypersensitive or hyper aware of. And rarely do I start to dive into any of those unless they're specifically asking my perspective. And I think what I've come to conclude, or at least this point in my career, is my goal commonly is not to like shift all of their beliefs at once, or maybe
Hmm.
at all during our time together, whether that's a few weeks or a few months, or even like a one-off session. It's to help guide them in the concerns or questions that they specifically have, and help them get to where they feel like they're in a better place in their life. And if them specifically asking my thoughts on this thing that they've been told before, or if I think this is a major barrier for us trying to move forward in a more productive direction, then it may be worth having that conversation. But I think it would be hard as a rehab provider, or almost impossible to try to tactfully navigate, or to tackle all of these narratives and beliefs that patients come in with, because there can be so many all at once. So
Hmm.
it is this like picking and choosing, and seeing over time maybe if they are directly asking you about it. And I think a big thing as well is just showing them that some of their maybe mis commonly misbeliefs are not correct, just by physically they can do more than they thought they could, or this certain position they thought was going to increase their symptoms or give them a flare up wasn't the case. So a lot of it is like them showing themselves. But do you have any thoughts of how you go about, like, not a decision tree, but for yourself or for other colleagues or for newer grads, trying to figure out when and if I should approach these things?
Yeah, lots of different ways to approach this. Um, I think if a couple of things come to mind. Um, if it's a new patient, I'm probably not going to try to debunk any beliefs in the first X amount of sessions. And that may be three, that might be 5 sessions, it might be until we're not in like month 3 post op. I'm pretty selective of when I try to debunk those, or at least challenge them. Um, what do I do? I think I will I will always listen to these various beliefs that they have, and I will always take note of them, and I'll always acknowledge them. It doesn't mean I have to approve or kind of deny them. right? But I'll listen to them. And then usually, you're trying to synthesize this information that they're giving you. And ultimately, you probably have your own mindset about what the end goal or what the interventions are that you're going to need to do to get to the final place that the athlete is looking for. And so when they finish their piece and I provide a summary or a kind of synthesis of what I found and what I think we're going to do, I usually try to say, just like anyone, it's like the way that you're going to get from where you are now to where you want to go is multifactorial. These are kind of our big heavy hitters as I see them. And you say, variable X, variable Y, Z. But I hear you. These other things that you're concerned about, they're likely involved in some capacity. I think they're probably on the outside of the bubble right now. And we're going to address them. But I think if you do these heavy hitters first, we can clean up those things that you're concerned about along the way, and we can kind of thread them in to your treatment or your plan of care. And so I think as long as most people know that they've been heard and that it will be addressed, they can get on board with your plan of care. And sometimes that's not how it goes. And I forget. I think you've had Chad Cook on your podcast, haven't you? I
Yeah.
remember listening to Chad Cook, and for your viewers, Chad Cook is like obviously probably one of the most prominent researchers, PhD out of Duke, that has looked into manual therapy and has done all these incredible publications, especially in like low back pain and cervical pain. And I remember hearing Chad Cook on a podcast once where he talked about he got fired by a patient, like meaning the patient and him met. Patient wanted this. He said, that's not exactly how we're going to do it. And so she went somewhere else. He's like, and I got fired, and that's okay. And I remember hearing that when I was a lot younger in my career. I mean, I'm still young in my career, but probably a couple years out. I was like, man, if Chad Cook can get fired, it is okay for us to get fired occasionally. Obviously, that's never the intent. And I'm not saying to anyone out there, if you've been fired by half of your patient care, there's probably something wrong. But sometimes you're just not going to click. And sometimes that athlete wants this one specific thing. And if you can't accommodate that in the best way that you can, while also staying true to yourself and staying true to what they likely need to get better, and they go somewhere else, that's okay. But as long as I think you were a good person from the start of the eval to the point that they decided they wanted to go somewhere else and you gave it your best and you were polite and respectful, it's like sometimes that's all you can do. Um, and so,
Can
yeah,
I add
I
something
get, I
there?
get, I absolutely, please.
Yeah, that just made me think of, I think, something that a lot of clinicians and new grads are fearful of if they aren't willing to give in to maybe certain requests that patients are hoping for XYZ treatment early on, that they're not going to be able to build that buy-in and that they're going to lose their patients. And then there's this almost
Hmm.
consistent concern that they need to have all of these potential tools of all these things that they could provide if a patient was requesting it, so they can do it to build quote unquote buy-in to allow for this process to start. And then maybe their argument is, what's the harm if I do some of these things and it's not doing any it's not harmful, and it can help us get into maybe the more productive sessions and treatment. And my bias, and having mentors like Derek Miles and other individuals that maybe are a little bit more uh, strict about what they're willing and not willing to do from just kind of a
Hmm.
placating symptoms perspective. And I've never had, let me rephrase it. I've rarely had instances where, as long as I'm extremely present with the patient, I'm listening, I'm understanding kind of what they've been told in the past, and I'm very communicative of what I think would be helpful for moving the needle forward. And with the limited time we have, once a week, twice a week, every few weeks, that I think these things are the most productive for us in this period of time.
Hmm.
All of the other things that you've mentioned, or maybe that you've had in the past, I don't have any necessary issue with you trying those or continuing them with another provider. Or if you want to receive hands-on manual therapy or massage, I would suggest going to a massage therapist where it's super
Hmm.
relaxing for an hour and you get all this time, or going to a provider that's certified in dry needling. And I never, or I rarely kind of like shit on those other things, but I just say during our
Hmm.
limited time together, I think these are the priorities. And if you want to seek alternative treatments, here are your options. And it's been rare that a patient's just left the clinic because I haven't done the thing that they were maybe
Hmm.
expecting or wanting initially. And I think that goes to the power of, if you're developing this early trust and rapport and professionalism and sense of like, um, I'm a healthcare professional that can provide guidance and options. And just because this thing that you have received in the past, I may not recommend we do in session, that you may not have as many patients leaving as you thought you did. So I guess that was a long way in saying, like, what are your thoughts with clinicians in how do they decide what type of treatments they should be comfortable with? Like, okay, this person just wants to be like cupped and dry needled, and if the rest of the session is good, then we can do it, versus, well, this is our limited time. These are the things that really, from, a capacity standpoint or return to sport, that we should really focus on. Like, where should clinicians draw a line in the sand? And is it just messy and gray and very kind of context dependent?
Oh man, it's probably very messy and gray and context dependent, I imagine, like everything else in this field. Um, it's a hard one. I believe, kind of what you just said about educating, typically with what their insurance is allowing, if you're seeing someone 2 to 3 times a week, or maybe less, maybe one time a week or once every other week, that's not a ton of time. And, to actually do like a good session of strength conditioning or rehab, it's probably realistically closer to, 75, 90 minutes. And usually we're seeing folks for less than 60. And so I think that's a really great way to kind of pose this. Like, we have limited time together. You were here to see me, physical therapist, to do active rehab to fix whatever the deficit is. In most cases, it's a strength deficit. And a lot of times I'll use objective measures, dynamometry, biodex, whatever, and say, this is largely part of the problem that we're addressing. And these, for the most part, we'll just call them these passive interventions. These passive interventions are not going to change this raw number right here that is, away from this metric that we're shooting for. We need to be doing active things that are going to get us closer to that number. And so it's hard. It's like an individual thing. It's like who the person is as a provider and what you believe in. I do believe in this setting that I work in, where we see athletes daily. Sometimes we see them, twice a day for a couple of days in a row. And we have unlimited access. And so I can't, I personally cannot fall back on we have limited time, because it doesn't work, because we live with these athletes. They live on campus, and I come to work on campus, and I see these athletes probably more than I do my wife. And so I can't always use that excuse, not excuse. I can't use that education, that angle. And so I do believe sometimes you have to give a little bit to get. And for the most part, if an athlete is aligning with my plan of care and they're doing the things that I ask, they show up on time, they're communicative, we have good discussion, we're doing all the right things, and other folks who are listening who work in high performance, they're going to get this too, as I know you do as well. It's like, I'm okay with doing 20 minutes of cupping if you've done everything I've wanted the last 3 sessions. And that's not my ratio all the time. Sometimes I have to bend that based on the scenario at hand. But I think as long as the interventions that they're asking for aren't necessarily harmful, there's very few things that are truly, really physically harmful. Again, dry needling and probably a poorly chosen cervical manipulation. As long as they're not actually hurting the person and they don't take up a ton of time, and I am not feeding them a new narrative that's harmful, I'm probably okay with doing some cupping or some massage at some point. And sometimes those things are helpful, but in more cases than not, the PT is spending their time somewhere else because we're trying to build capacity or strength or whatever you want to call it. We just have other priorities that we have to work on when someone is seeking our services.
Yeah, the college setting, or for sure the professional or the elite setting, where, like you said, there's daily sessions or multi-day sessions with the rehab and performance department. That's much different than the vast majority of other settings in orthopedics or sports where you're seeing a patient maybe 2 or 3 times a week. And there is that limited time component. But when you have all the resources in the world as a professional athlete or high level athlete, and you want to get some extra time with cupping or massage, and you are being told by your rehab provider, hopefully, that there's nothing magical about this specific treatment. Hopefully, it kind of settles you down and makes you feel good for a period of time and kind of relaxes you for the more intensive things. That's all it's doing. You have a wide range of options, whatever you want to
Mm-hmm.
get. You probably have all of them at the Olympic Training Center or this professional or collegiate organization. Pick your options. Hopefully, or ideally, that's the messaging, that they are all kind of doing the same feel good thing. If you want some, here are your options. But I'm assuming you'd agree, the vast majority of time, that's not how it's discussed or brought up or laid out. It's way more nitty gritty. It's way more incorrect of what's being told as
Mm-hmm.
to why they think or are wanting this thing. And I think that's the point of this conversation, is that none of these things, like you said, are rarely actually physically harmful. None of them are really that powerful in the sense of that they just kind of placate and feel good for a little bit of time.
Mm-hmm.
But people are coming into it with such strongly held beliefs that they either need it or that it's realigning or it's doing these things that it's not. And that's where it becomes frustrating and unfortunate.
Yeah, absolutely. And I mean, as you know, folks come in with a wide range of different beliefs, and I will say at this setting too, um, it depends on the age of the athlete and the experience level of the athlete, and sometimes it just comes from a place of like not being experienced around sports medicine. And folks come in for a session with me, and they signed up. I hate to say this, but here at the training center, they signed up because they may have been bored. We have a lot of camps that come through, and these camps are younger developmental athletes, and they've never had full access to legit, really high quality sports medicine. Like, I'm going to go in and try this, just like anyone else would just go, hey, let's go try this out and see what it's about. And what do you think PT is? Maybe it's massage, or maybe it's hands on. Probably feels good. And so usually in scenarios like that, it's like we discuss. And if I feel like it's kind of blurry about what the session is, I'll just politely ask, like, what do you hope to get out of this session with me? And then sometimes I'll joke, like, the answer is it can't be a full body massage. Like, your time with me has to be specific. And if there's nothing specific you want to work on, I have some other providers that may be better suited for you on what you're looking for. And generally, as long as there's some specificity, 99% of the time, I'm like, I'm down for that. Say you're not injured, but you want to work on an injury prevention or injury, risk reduction program. I'm down. We can spend some time there and make some benefit there, but there has to be a goal. And so in the outpatient world, generally folks come with a script, or they come with you because they're in pain. Very rarely someone comes to an outpatient PT clinic because they're bored. But it can happen. And sometimes a little bit of education can kind of funnel in a direction that's much more purposeful. And if they're not vibing with it, it's maybe you're just looking for soft tissue services or like a relaxation type massage type thing with a great massage therapist. And I have plenty of those too, and that's valuable, but that's not going to be the relationship you have with me. And so there's a little bit of that too.
Let's switch gears a little bit to more of the
Sure.
colleague or coworker side or other professionals that you may be interacting with either in-house on a daily basis, either your personal experience or just in the general theme of other clinicians in a setting where they're working with other colleagues, or a therapist or a patient or athlete is coming in and they're being co-treated or seeking treatment from an outside provider, whether it's another physio, a chiropractor, a massage therapist, whatever it is. And you're having to also kind of manage the things that are being told concurrently during this period of rehab. Do you have
Mm,
any either examples or ways that you've navigated those contexts?
that one's also really hard. There's a spectrum of scenarios of, you're working alongside your coworkers or other folks in clinic, ranging it from a you have a student that's underneath your care, to you have a colleague who's the same age and experience level as you, to you have your boss that's been in the gig a long time, but they have some beliefs and some treatment preferences that probably are not very productive. And I would likely manage all those differently. And you could probably get a variety of folks to answer these differently than how I would. Um, for the most part, if someone is threading in some of these treatments in their session, and by threading in, it's like they're doing other things that actually packs a punch in terms of helping the patient, and they thread it in occasionally at the end of the session, or it's coupled with another belief to, or coupled with another intervention that they know is going to be more impactful. I can keep my mouth shut, and I can appreciate there's probably some nuance to that I don't understand watching from across the room. And I would never interrupt a session and put another colleague down or provider down in front of a patient. It's never going to be the right answer. And there are folks out there who that's how they would address that. Certainly if it's a student, I'm probably going to intervene afterwards and be like, hey, don't do that. Or let's talk about that and hear your deeper train of thought as to why you did that. And then I challenge them, if you think that's what the issue is, if you think it is an innominate rotation, I challenge you to do the intervention and not supply the narrative as to what it's doing and see what happens. And I don't think that's typically how, innominate correcting or leg length correcting techniques are done. Usually there's a lot of education up front, and then there's a lot of positive priming on the back end. Oh, doesn't that feel better? And look at it, and look at your malleoli. They're great. I challenge them to do the intervention relatively quickly, and then move on to whatever it is that they need to accomplish for the session. And I think that's how I would typically do it with students. Now, someone who is your senior that you see that's how they're practicing a lot, that's hard, and it depends on the relationship that you have with the senior provider or your supervisor or your boss. And a lot of times, you're probably not going to change that if that's what they've been doing for a long time. I think that's a scenario where you kind of lead by influence. I think your patient outcomes for the most part should probably speak to your skill set and your relationships with patients, and that can help influence folks in the right direction. But for the most part, I think some of these can slide as long as it's coupled with other impactful interventions. I will say, though, one case where I'll probably get a little bit fired up and I might say something is, and there's folks who do this. It's, there is a patient coming in for a bulk of rehab that they need for their problem, and that provider shrinks the amount of work and attention they need to do an innominate rotation correcting technique that takes a 60-minute session down to a 10, and then they have 50 minutes left to do their notes. I don't vibe with that. That's not right by anyone. And there are some folks who actually truly believe that's what the patient needed, but I would say the majority of folks who do that are trying to decrease their workload for the day and get some time themselves. And I've been around that, and that's one I'll probably say something to that coworker, because I don't think that's fair to the patient. And the patient leaves and they're super confused. I don't know if you've been around that or if you've seen that in practice, but I've encountered that a couple times.
Yeah, I haven't encountered that specific example, but the first clinic I was at as a new grad for 2 years was a combination multidisciplinary clinic that had physios and chiropractors and athletic trainers and in-house orthopedic surgeon and his PA and massage therapists. And there was a wide range of things that were being told. And a lot of patients were receiving care from a lot of different providers. And that's where it got messy, because on the rehab side, I think we had very inline beliefs as a group, the 10 of us or 8 of us, whatever it was. And then across different specialties, it became messier and messier. And that consistency of messaging and plan of care was kind of lost. And trying to balance how to manage this with a patient where they have potentially trust in all of the providers that they're seeing, or the highest trust in their orthopedic surgeon who's telling them something, and then their chiropractor's telling them something, and then we're telling them. And it's like, how do I pick and choose how to go about this without disrupting relationship that my patient has with these other providers and the relationship I have with my coworkers. And I don't know if there's a right answer, but I think it goes to those situations where there should be maybe a group conversation about managing this case as a whole, if it's kind of a concurrent treatment throughout a plan of care, and what are we in line on, and maybe what are your priorities as this provider, and we're okay, or that's where you spending your time and effort, and what are their priorities as myself as a provider. And there has to be some wiggle room, and like you said, it's just dependent on kind of maybe the hierarchy status and the specific context. But it is just challenging for a lot of clinicians where they're in an environment where they're around other clinicians, or they're with other disciplines that are also treating their patients, and you're trying to maybe provide a more appropriate message or more empowering message, and then they're getting almost the complete opposite, kind of fear mongering or fragilista beliefs about their body. And that's, I think, one of the hardest, that sometimes it can be managed, and sometimes that person will ultimately lean into the provider they've just worked with the longest or they trust the most, and it may be a losing battle. Or those situations like you said with the Chad Cook example where a patient just leaves you because you're maybe not providing the type of care or messaging that they are wanting or expecting or hoping, and they go to someone else, or they lean into the other individual that they've worked with longer. So it's tough.
It is tough. And yeah, I think there's probably different viewpoints on this. I think for the most part, patients or athletes need a lead. I mean, everyone listening to this podcast, if they've worked in a clinic, can picture someone that has bounced around from clinician to clinician, whether that was intentional or unintentional, meaning the front, the admin staff just was putting them with whoever was open, or the patient or the athlete was shopping, which also is a thing, and that has a positive connotation and a negative connotation. It's like you want to find someone you vibe with, but if you also want to find that one PT that's the weak link that you can turn your 60-minute session into a massage, and that's why you're shopping, that's obviously not ideal. But there certainly has to be a lead. A co-treat can work, but even between the co-treat, usually there's someone who sees that athlete more. And if I sense that I am one of the cooks in the kitchen of an athlete who's being seen by a lot of folks, I usually will say at the end of it, look, I see that you've seen a lot of providers. I encourage you to make an effort to schedule with whoever it is that you're vibing with most. Like, do a vibe check. Who is that? Who are you enjoying seeing the most? And that aligns kind of with what you're looking for. And I was like, that might not be me. That's totally fine. I think you need to get a good, clean train of thought and plane of care with with one mindset. And because I'm seeing that you're struggling in a variety of different ways because you're seeing so many folks. And I think most people appreciate that. It's like, I want to be as involved as much as you want me to be. And that I can be your guy for the remainder of your care, or I can just be someone that greets you at the front desk and give you a fist bump after you have a good Biodex test. I'm happy to do that. Just let me know what you need to be most successful. And then I was going to say too, going back to your original point of all the different providers involved in a patient's inner circle. Like I have seen physician assistants in an exam room with the orthopedist there telling patients that their innominates are rotated. Like when they're in for something that probably structurally needs to be addressed, I have seen PAs do that. And then, I mean, like on the hierarchy, like I'm speaking to this traditional rigid medical hierarchy that everyone knows that is in the medical field of like PAs, you're attached to a physician, and usually what a PA says is going to have some strong belief, or not belief. It's going to have, the patient is going to adhere to that, and they're going to really take that for gospel. And then they bring that to PT. And it's like, that's probably a patient I might do the little nominate thing on, and then we move on, because otherwise they're going to feel like they've potentially been neglected based on intervention, based on advice they got from someone else. I know I'm rambling, but definitely the patient who gets tossed around and hears a lot of different beliefs, it can be very hard to navigate.
Yeah, I had actually an experience yesterday with a new remote client who has had this kind of acute on chronic low back pain episode that's very intense. He said it was so bad that he was bedbound for a week and was on a steroid pack and has now shopped around for in-person or online help. And when we had our call yesterday, it had been, I think, about 2 months since his onset of symptoms, and he had already seen maybe 8 to 10 different physios or chiros,
Yeah.
and trying to figure out, am I the last person or am I one of 10 more? And how do I navigate that, knowing that he may be concurrently like, again, shopping around for other opinions and views and thoughts. So I just explicitly asked him during our time together, are you expecting to reach out to more individuals, online coaches or in-person providers? And he said, no, for this month, I really want to try this. And I don't
That's
know if
good.
that's true or not, but it gives just some idea of this person's constantly seeking tons of different opinions. And the last person he saw was a McGill certified provider that provided
Yeah.
very different narratives and beliefs that I want from a messaging standpoint during at least the month that we have together. So just knowing where someone's coming from, how many people they've sought out or are concurrently working with, it just adds layers and potentially messiness or clarity to an interaction.
Yeah. I mean, I think I usually use the instructions of, it's like any math equation or it's like any piece of research. Like to find the outcome you want, I would manipulate one variable at a time. And I would probably not have 7 different variables working on you at the same time, meaning you and other providers. And it's like, again, it doesn't have to be, and I mean, this, like, it doesn't have to be you, like, you don't have to be their provider, but it's like, we need you to pick someone and give it some time because ultimately that's how you're going to figure out what's working and what's not. And if it's not working, I don't know, give it X amount of weeks. And then if it's not working out and you don't think it's being impactful, then you chat with that provider or potentially move on, and that's fine. But don't shop and not give anything longer than 2 days of compliance before you say it's not working out. And a lot of people do that. And there's so few quick fixes in physical therapy. And I think about this a lot. It's like BPPV, like you can probably make that better in one session, arguably a couple. It's like maybe cervical manipulation for someone who slept funny, and then I don't know, maybe dry needling for like I'm using air quotes for the listeners for a trigger point that really needed a dry needle. It's like there's so few quick fixes, and people want that, and we just don't offer that typically. You know?
Yeah, totally. But that's hard to get across where a ton of different providers are saying that messaging that they will cure your symptoms
Yeah,
quickly, and there's that
totally.
overconfidence that patients want. Anything else, Chris, with this conversation that you want to touch on further or add before we start to close things out?
Yeah, no, that's a fair question. I and I think you've echoed this in other episodes of this podcast. It's like at the end of the day, you should probably always be leaning in towards being a guide for your patient instead of a savior. It feels really, really good to find to make an answer or to craft an answer for that person's pain and then give an intervention that you think is going to fix it right then. It feels great. It feels really nice when you help someone, and I don't think anyone gets in this gig to not help someone. But I think as long as you're checking yourself for, am I being a guide or am I trying to be a savior? And if you're being a guide, you're probably in the right place. And if you're in the other direction, you probably need to take a step back and think about some of your beliefs with the interventions you provide or the narratives you provide. And I think as long as you have that in mind, for any students that are listening and might have a CI that there's some funny things, I'd encourage you to think about that frequently to kind of help keep you grounded. But no, I think that's the last thing that I kind of had in mind.
Yeah, I think that's a great place to stop. Chris, this was a great conversation. Hopefully people find it helpful, and also maybe give some context that each context is different with each patient and athlete, and trying to navigate these things is messy, and sometimes you don't get it right, or sometimes you don't click with an athlete, and you don't have to try to fix or change everyone's beliefs. And there are contexts where you just kind of keep it the same, or do things where, maybe you wouldn't do it where there wasn't a time component or whatever it is. So hopefully people can resonate with some of these experiences or examples and maybe give some relief that you're not alone in trying to navigate this with your patients or athletes or coworkers. So yeah, Chris, I appreciate you coming on. We'll call it there.
Thanks for having me.